Hi, and welcome to Chapter 9, Lesson 9, Severe Asthma. So, we're going to describe the basic mechanisms for asthma as a cause of respiratory distress, distinguish between respiratory distress and respiratory failure, and describe the history, signs, and symptoms of severe asthma attack. We're going to outline in detail the wilderness protocol for the treatment of severe asthma, including drug dosages and routes of administration. And we're going to describe the situations in which asthma would justify a high-risk evacuation. And we're going to describe the long-term management of the asthmatic patient when evacuation is unsafe or impractical. So asthma is a chronic Asthma is a chronic inflammatory disease that causes lower airway constriction. The mechanism involves both spasm of the smooth muscle walls and swelling of mucous membrane line of the bronchial tubes. Acute asthma attacks are sometimes triggered by infection, cold air, exercise, or other stressors. Sometimes asthma flares without apparently any reason at all. Some patients need to use medication daily to keep their asthma under control. So mechanisms are chronic inflammation of lower airways, acute exacerbations of bronchial spasms and swelling. It can be triggered by exercise, cold air, infection, and can be mild or severe. In our assessment, we're looking for a history of asthma. We're listening for wheezing, coughing, the complaint of chest tightness, and respiratory distress, and prolonged forced expiration. So asthma attacks. An asthma attack can be mild or severe. It can be major critical system. It could be a major critical system problem, and when it causes respiratory distress. If bronchial spasms are allowed to persist, the lower airway constriction will be exacerbated by secondary swelling. Early signs and symptoms include respiratory distress, chest tightening, wheezing, and non-productive cough. Most people with asthma are aware of the condition and are familiar with its representation. Acute symptoms are usually relieved with self-administration of medication such as inhaled albuterol that reverses the chronic characteristics of bronchial spasms. Occasionally, an asthma attack will not respond to inhaled medication, and this is usually due to the patient waiting too long to administer it or not having it with them. Okay? Also, just want to say, if somebody says they're wheezing and are asthmatic, and even if you can't hear this, I know we stress this during respiratory issues, but if they say they're asthmatic and they can't hear it, you can't hear them, just believe them. They know what it means. Okay? So when treatment is delayed or ineffective, the initial bronchial spasms in the lower airway is made worse by secondary swelling. At this point, it will be difficult or impossible to deliver inhaled medications to the bronchioles where it can exert its effect. Severe respiratory distress can rapidly progress to respiratory failure, at which stage respiration will be labored, and the patient will be able to speak only in one or two words between breaths. So we talked about this before during our respiratory emergencies, correct? Emergency treatment is required. It should not wait for the evacuation or for ALS to be brought to the scene. You should first assess your patient with the proper use of his or her HFA inhaler. Be sure that you're using the fast-acting bronchodilator. The patient may recognize this as his or her rescue inhaler, quote unquote. The distinction is important because some patients also use inhaled steroids or other medications as an adjunct to their therapy. These do not act fast enough to help in an acute attack. Okay, so you want to use the rescue inhaler only. Encourage the patient to inhale deeply as possible while the inhaler is discharged into the mouth. the efficiency of the inhaler can be improved by the use of a spacer to contain the vapors while the patient inhales. This is simply just a plastic tube at the end of the inhaler and the patient on the other. You can improvise a spacer by using a plastic bottle with the end cut off. Once the patient has inhaled the medication as deeply as possible, have him or her hold the medication for a few seconds before exhaling. So you want it to sound something like this. First of all, you want them to exhale as much as they can. And once it's all exhaled, you're going to have them put their mouth on a spacer. They're going to spray the medication, and you want to make sure that that spacer is void of any medication or as much medication as possible before they exhale. It's safe to make several attempts to abort the asthma attack with an inhaler. However, do not delay in moving that next step if it's apparent that the patient cannot effectively inhale the medication. If you use an inhaler and it fails to reduce the symptoms within a few minutes, the patient will need an injection of epinephrine. Before medications like albuterol became available, epinephrine was the first-line treatment for an asthma attack. It's the same medication as we talked about for anaphylactic shock, right? And it is given in the same concentration and dose and in the same way. So you can use that EpiPen if you have it, for the asthma. Okay. So Wilderness Protocol for severe asthma calls for 0.3 milligrams of epinephrine injected in the lateral aspect of the thigh, and for children a dose of 0.01 milligram per kilogram up to 0.3 milligrams. The patient will usually feel better within a few minutes, and one dose of epinephrine may completely abort the asthma attack, but a second dose may be given within as little as 5 minutes if needed, and only if needed. Once the symptoms improve, the patient should self-administer his or her own inhaler dose up to 6 to 10 puffs, or up to 3 times over the next hours. Each 6 to 10 puff dose is roughly equivalent to a nebulizer treatment in a clinic or a hospital. If evacuation is likely to take more than 3 hours, add a dose of prednisone or 1 milligram per kilogram given by mouth, of about 40 to 60 milligrams for an adult, 20 milligrams for a child. As with anaphylaxis, this will reduce the lower airway inflammation and the chances for another attack. So we're reducing the chance for another attack. All right. So, what is a risk benefit? This protocol is used for severe respiratory distress leading to respiratory failure caused by lower airway constriction and in a known asthmatic. It is safely effective and it carries little risk compared to the problems associated with inadequate oxygenation. Okay, and it is an important life-saving skill for both basic and advanced practitioners operating in the remote areas. This is one of those skills that we're going to go over in the field skills testing, is using the inhaler, the rescue inhaler. The disease itself can become a significant problem when the triggers cannot be avoided. Asthma can generate significant lower airway inflammation, and continue wheezing with which exacerbates that may continue for several hours or even days. So people can have wheezing for a long period of time if this isn't taken care of, and it could lead to death. So even if the initial attack is completely aborted, the risk of further exacerbations may warrant evacuation from the field, especially if you don't have medication and they have a history. This is one of those times that you want to get them off the field. Now, does it require an emergency evacuation, such as calling a helicopter in to take the patient away? Maybe not. But if it's a lot of exercise and the asthma is caused by exercise-induced asthma, then do we really want them to walk that 2-3 days out? Will they have the chance of having a relapse episode? So if that's the case, maybe a helicopter and or vehicle extrication is definitely warranted. Ideally, anyone whose life you've just saved with epinephrine should receive early follow-up of medical care. If the symptoms are under control, evacuation may not be an emergency one. Okay, but in settings where evacuation is unreasonably dangerous or impractical, prednisone can be continued daily for up to 5 days, just like we would do with the anaphylactic patient. The patient should continue to use her own inhaler as needed. Okay, so it's a pretty quick lesson here. So if you need to do it, go back through and listen to it again. And again, if you have any questions, feel free to email me. So what do we go over? Asthma causes lower airway constriction, and if severe, respiratory distress into respiratory failure. The Wilderness Protocol for severe asthma calls for 0.3 milligrams of epinephrine, right, by intramuscular injection, followed by albuterol and by inhalation, and up to 40 to 60 milligrams of prednisone orally. The following treatment, evacuation for medical follow-up, is ideal. In high-risk and remote settings, continued monitor on the use of albuterol and prednisone for several days may be indicated. Okay, so that's our follow-ups here. Those are the key points of this particular thing. Get the asthma, the initial attack under control, and then evaluate for evacuation. Again, if you have any questions, email me at admin@wemt.org, or if you're taking my class and you're enrolled, you'll have my number. Anyway, we'll see you at the next lesson, which is going to be covering diabetes and hypoglycemia.